When a patient's cardiovascular system fails to perfuse tissue, physiological deterioration occurs with high velocity. The body triggers a cascade of compensatory mechanisms that, if left uncorrected, lead rapidly to a complete systemic crash. At the bedside, this looks like a flood of conflicting data: hypoxia dropping below 90%, peaked T waves on the monitor, and sudden, unexplained confusion. In that moment, you must answer one question: what is the priority intervention? Proficiency in anatomy and pharmacology fails at the bedside when a clinician cannot objectively rank competing physiological threats. To survive these scenarios, every clinical decision must be driven by a single rigid calculation. Mathematically, what specific factor will kill this patient first? Standard linear care protocols often break down during a multi-system failure. Success requires a rigid algorithmic pattern recognition system that forces the clinician to act on the immediate physiological threat. This 6-tier triage algorithm aggressively strips away clinical distractors. Raw patient data enters at the top, and as it drops through these specific filters, secondary symptoms are caught and held back. The top of the hierarchy focuses on the absolute physical baseline. Airway and breathing dictate survival. Physiological oxygen needs override psychosocial anxiety, no exceptions. The middle layers apply a temporal filter. The system catches acute, unexpected changes while allowing chronic, expected findings to pass through as non-emergencies. The final layers address action. Unstable presentations supersede stable ones. If the patient is actively decompensating, the filter rejects further assessment in favor of an immediate physical intervention. This filtering process provides the only objective method for identifying the most immediate threat to life in a complex clinical scenario. We can test the temporal layers of this filter by looking at the respiratory system, specifically a patient with a chronic lung disease. In this scenario, a patient with chronic obstructive pulmonary disease, or COPD, presents with an oxygen saturation of 91%. This diagram compares healthy gas exchange to the structural reality of COPD. Years of inflammation have destroyed the alveolar walls. Air enters, but the damaged structures collapse during exhalation, trapping air inside. Because their carbon dioxide levels are chronically high, the patient relies on a hypoxic drive, a low level of oxygen, to stimulate their breathing. Because of that structural damage and neurological adaptation, an SpO2 of 91% is an expected chronic baseline finding. When we run that data through our triage algorithm, it passes through safely. If a clinician applies 100% high-flow oxygen to this patient, they eliminate that hypoxic drive. The patient's brain senses the oxygen surge, stops the signal to the lungs, and the patient ceases breathing. The correct intervention is highly targeted. Apply low-flow oxygen to strictly maintain an SpO2 range of 88 to 92. On the right, HHS kills through profound cellular dehydration, as massive amounts of glucose in the blood pull water out of the surrounding cells. Despite these different mechanisms, running both conditions through the severity filter yields the exact same immediate physiological priority: severe vascular volume depletion. Both patients are dangerously dehydrated. The non-negotiable first action for both conditions is the administration of intravenous fluids before any other medication is considered. Administering insulin before replacing that fluid volume triggers a massive shift of glucose and water into the cells. This depletes the already strained vascular system, leading to a hypovolemic crash. In complex metabolic emergencies, stabilizing the raw physical volume of the vascular system must precede correcting the underlying chemical anomaly. The final layer of the algorithm protects against the assessment trap, the habit of attempting to gather more clinical data while the patient is actively dying. The universal pattern of clinical shock is sudden hypotension, tachycardia, and an altered mental status. When that triad appears, selecting any diagnostic option, like checking the patient's pain level, wastes critical time. You already have the data that proves the patient is crashing. The only correct response to active decompensation is an immediate doing action. You must establish IV access or administer oxygen. Acute kidney injury provides the ultimate test of this intervention threshold, specifically when the failing kidneys allow potassium to build up in the blood. This ECG tracing shows what happens when potassium levels climb above 5.5 milliequivalents per liter. The excess potassium begins to directly poison the heart's electrical conduction system, forcing the T waves to rise into these towering peaks. Peaked T waves indicate that cardiac arrest is imminent. All standard kidney assessments are now secondary to cardiac stabilization. The immediate, required intervention is the intravenous administration of calcium gluconate. Calcium gluconate functions as a chemical shield, stabilizing the cardiac membrane to buy time for secondary treatments to actually remove the potassium from the body. Recognizing a fatal physiological pattern requires the clinician to bypass diagnostic curiosity and move directly to a physical intervention. There is one high-stakes scenario in the neurological system where the strict action over assessment rule reverses, and an assessment is the required life-saving intervention, the acute stroke. This diagram compares the two stroke variants. An ischemic stroke occurs when a physical clot blocks cerebral blood flow. A hemorrhagic stroke occurs when a blood vessel ruptures, bleeding directly into the brain tissue. The time-critical treatment for an ischemic stroke is the administration of a clot-busting drug known as TPA, which must be given within a strict 3 to 4.5 hour window. If you administer that same clot-busting drug to a hemorrhagic stroke patient, you will dissolve the body's attempt to clot the ruptured vessel, worsening the bleeding and causing death. Because the clinical presentation for both strokes is identical, the mandatory first action is a CT scan without contrast to differentiate the two pathologies before any medication is given. When the definitive life-saving treatment for one condition is instantly lethal to an identical-looking condition, high-level diagnostic imaging becomes the highest priority intervention. Let's run multiple distinct pathologies through the 6-tier filter at maximum speed to see how pattern recognition dictates triage across different organ systems. First, cardiac tamponade presents with Beck's triad, hypotension, muffled heart sounds, and jugular vein distension. Fluid is crushing the heart muscle. The nurse must assist with a pericardiocentesis to drain the fluid and restore cardiac output. Next, neutropenic fever. An immune system this compromised cannot wait for blood culture results. You draw the cultures, then immediately start broad-spectrum antibiotics. An Addisonian crisis presents with hyponatremia, hyperkalemia, and hypoglycemia. The sequential intervention is IV fluids first to prevent circulatory collapse, followed by IV hydrocortisone. Finally, retinal detachment. The immediate priority is immobilizing the head to prevent the tear from widening before surgery. Regardless of the organ system, every distinct medical emergency is solved by trusting the recognized pattern and identifying the fastest path to physiological harm. Clinical judgment demands the disciplined application of a rigid prioritization framework to navigate bedside data. The ultimate goal of the triage algorithm is to intercept physiological collapse and pull the patient back to a state of baseline stability. Protect the airway. Hunt for acute, unexpected symptoms. Identify the unstable patient. Execute the decisive physical intervention. Adhering to this algorithmic hierarchy allows a nurse to navigate complex exam scenarios and prevent rapid clinical deterioration on the medical surgical floor.